Good afternoon, ladies and gentlemen. Welcome to the 37th Erlangga Webinar Conference Series, Advances in Urological Cases in 2020, Webinar Series 3, Sexual Medicine. My name is Wina, along with my senior, Dr. Ahmad Heriana, Specialist of Pediatrics, and my colleagues, Dr. Imran, Dr. Corin, Arya, and Rahul. We are the organizing committee members of this afternoon webinar. This webinar is organized by the Faculty of Medicine, Universitas Airlangga, Surabaya. We are happy to announce you that up until now, the registrants have reached 789. Before we proceed to the main event, we will announce some of the rules regarding the certification and Q&A session of this webinar. Rules for ED accredited certification. Full participation during the webinar is required. Your attendance will be recorded by the Zoom application. By the end of this webinar, participants are required to fill a questionnaire, which the committee will send to the link of in the chat box. The certificate will be sent to your registered email address. Next, rules for Q&A. Use the Q&A box on the middle of your Zoom panel to write down your questions. Questions will be sorted and discussed after all lectures have been presented. Thank you for your participation, and we sincerely hope you enjoy this webinar. We will start this event with an opening remarks by our beloved host, Dr. Anak Agung Patriana. Dr. Anak Agung Patriana, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen, all participants and speakers. Welcome to the third series of the 37 Fiesta Urology in conjunction with the 37 Erlangga Webinar Conference Series. My name is Patriana. I'm very honored to be your Master of Ceremony in this beautiful Friday, 20th of November 2020. Before we start our webinar, let us sing the Erlangga hymn. Today's topic is sure to grab your attention. It will bring so much excitement because we have a very interesting topic today. It's about sexual medicine. And we have international speaker in the last session of our webinar. So keeping up with us until the next 2 hours, and don't forget to drop your questions on the Slido. We will provide the link on your chat room shortly. Without further ado, please welcome our honorable moderator, Professor Dr. Dodi M. Subadi, Specialist of General Surgeon, Specialist of Urology Consultant. Prof. Dodi is specializing in andrology, consists of sexual dysfunction, male reproductive medicine, and surgery, especially microsurgery, as well as voiding dysfunction. He is a founding member of Endourology Society of Asia and international member of European Association of Urology, American Urological Association, International Continent Society, and also the Dutch Urologic Association. To Prof. Dodi, the time is yours.
Thank you, Dr. Patiana. Dear colleagues and friends, a very good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Namaste, Om Swastiastu, Salam Sejahtera. Thank you for participating virtually in this event. This is an event of our program, Fiesta Urology. It's a scientific and social meeting of Urobaya, means that Urology of Surabaya, and the alumni of this urology program from all over the Indonesia gather for a reunion, and usually consists of courses, discussion, and seminars, and of course, a lot of fun. And like this, I would like to share some picture with you. And we have also, we have a fiesta in Makassar, in Lombok, and now in Surabaya, but unfortunately only a virtual. And we gather with a lot of fun, like this gala show of our resident in Candi Prambanan or Prambanan Temple. In this occasion, we are very honored that we will have two guest speakers, prominent guest speakers, Dr. Vinit Maltora from New Delhi, and Dr. Oki Ding, our best friend in andrology and also a pioneer in IVF and reproductive medicine. And he's world renowned, and we will discuss and share in the special field of sexual medicine, the problem of male infertility. And the first speaker, Dr. Ayudhya, will present about the male infertility and sexual medicine. Dr. Ayudhya, time is yours.
Thank you, Prof. Dodi, for the introduction. Screen sharingnya nggak bisa. Screen sharing saya nggak bisa. Yeah, thank you very much for the kind introduction. I am tasked today to discuss sexual dysfunction and male infertility. So, male infertility here is, of course, we start with the definitions where this is a disease of the reproductive system defined by failure of achieving a clinical pregnancy after 12 months of regular unprotected sexual intercourse. Ini karena pesan ini atau definisi ini sangat penting, saya akan ulangi lagi bahwa ini dari WHO, tidak hanya bahwa ini didefinisikan ada durasi dan bahwa ada kehamilan, akan tetapi dari WHO mulai disadari atau diterima bahwa infertilitas ini tidak hanya keinginan orang memiliki anak, akan tapi juga suatu keadaan penyakit. Di mana di sini bahwa infertilitas pria atau male infertility ini adalah infertilitas di mana didapatkan faktor dari laki-laki. Berikutnya bahwa sexual dysfunction di sini adalah salah satu problem yang ternyata sangat dekat terkait. Sexual dysfunction is related to male infertility. And I will, in this talk, try to explore what are the links between sexual dysfunction and male infertility. So, yes, apologies that there's some problems with sharing the slides. Yes, okay. Slide. Yeah, so sexual dysfunction in general, this is a problem at any point of the sexual response cycle. Ini siklus atau siklus ini pertama dipopulerkan sudah beberapa puluh tahun yang lalu oleh Johnson dan Masters, dan kemudian sampai dengan saat ini masih kita kenal bahwa itu dimulai dari harus adanya suatu desire, diikuti arousal atau rangsangan, dan kemudian berpuncak pada puncak kepuasan seksual atau orgasme, dan di mana pada laki-laki ada periode refrakter setelahnya itu. Slide. Nah, what are the male sexual dysfunctions that is commonly seen? When we start with the desire, there's low libido, there is erectile dysfunction, ejaculatory dysfunction, especially premature ejaculation. However, as urologists, we also deal with physical abnormalities of the penis, such as Peyronie's disease and other deformities. Slide. Ya. Meskipun disfungsi seksual ini sering kita dapatkan, previous slide please, but this is still considered as the rare cause of male infertility, which falls under a pretesticular cause. Saya kira cukup bisa kita pahami bahwa apabila ada disfungsi seksual, ini akan berakibat bukan keadaan yang optimal untuk bisa terjadinya konsepsi, di mana harus bertemunya antara sel benih dari laki-laki dengan sel telur dari wanita. Slide. Seberapa sering atau seberapa kerap dari kejadian infertilitas pria ini, infertilitas disertai dengan disfungsi seksual, ini tentu prevalensi seperti ini sangat tergantung populasi apa yang digunakan dan tools atau instrumen apa yang digunakan untuk mengukurnya. Sehingga angka-angka di sini tidak bisa kita terima begitu saja, harus dilihat dengan konteks itu bahwa infertilitas pria ini bisa mencapai 12% dari semua pria, dan kalau di antara pasangan, couples yang berusaha untuk mendapatkan anak, maka mungkin pasangan di sini 9% ini mendapatkan atau memenuhi kriteria diagnosis dari infertilitas. Untuk disfungsi seksual, dari berbagai macam disfungsi seksual yang tadi sudah saya sentuh sebelumnya, bahwa sampai dengan 20 atau 30% apabila dilakukan kuesioner ataupun pertanyaan, maka mungkin ada derajat tertentu dari disfungsi seksual. Slide. So, what is the link between male infertility and male sexual dysfunction? Is there a direct link? Apakah ini berhubungan secara langsung, ataukah ini adalah suatu hubungan yang melalui gangguan atau psikis atau psikologis? Tentu saja kita tahu bahwa infertilitas pria di sini infertilitas pria adalah sesuatu yang sangat naluri alamiah dari setiap orang, setiap pasangan, bahwa ada keinginan untuk meneruskan materi genetik ya, atau meneruskan keturunannya, sehingga apabila di sini ada kesulitan atau kegagalan, maka infertilitas ini bisa disertai dengan gangguan psikopatologi. Baik itu apakah ansietas maupun depresi, di mana kita tahu bahwa ansietas dan depresi ini cukup jelas merupakan komponen yang penting apabila adanya gangguan disfungsi seksual. Slide. So, is male infertility a cause of dysfunction? We know that sexual dysfunction is more prevalent, didapat lebih banyak disfungsi seksual pada laki-laki yang infertil. Dan infertilitas ini kalau memang terjadi, ini mengakibatkan suatu gangguan yang mempengaruhi seluruh aspek kehidupan, all aspects of life in couples. Slide. Sementara itu, slide. Nah, kita dapatkan kembali bahwa seringkali tidak hanya ini ada faktor laki-laki dalam infertilitas, itu bisa saja diperberat kondisi atau disfungsi ini, di mana ada female infertility atau juga female sexual dysfunction, sehingga ada lingkaran setan antara infertilitas dan disfungsi seksual baik pada pria maupun wanita. Slide. So, di sisi lainnya, apakah sexual dysfunction ini menjadi kausa dari infertilitas? Terutama yang dikenal adalah dua ini. Satu, tentu saja disfungsi ereksi sebagai salah satu fungsi seksual utama yang bertujuan untuk meletakkan sperma di dalam traktus genitalia wanita. Ini kalau misalnya ada disfungsi ereksi, ini tentu akan mengganggu fertilitas. Hal ini mungkin di dewasa ini dengan usia paternal yang mungkin makin lama makin meningkat, maka disfungsi ereksi ini juga akan makin sering kita dapatkan. Sementara itu, gangguan ejakulasi, apakah itu anejakulasi atau ejakulasi dini dan retrograde ejakulasi, ini tentu saja apabila sperma tidak bisa mencapai sel telur dari wanita akan menjadi infertilitas. Slide. So, sexual dysfunction tentu mulai kita dari fase pertama dari sexual response, yaitu harus ada desire atau kita sering sebut sebagai libido. Libido ini bisa kita eksplorasi lebih jauh dengan kuesioner, menanyakan secara langsung dari libido, akan tetapi juga kuesioner ini kita men-screening apakah ada kelainan hormonal yang mungkin seperti testosteron yang rendah, yang juga manifest atau mengalami gejala klinis. Contohnya di sini adalah kuesioner ADAM atau kuesioner aging male, yang bisa ditanyakan apakah pasien merasa kurang energi, bertambah lemah, atau misalnya merasakan keluhan-keluhan psikis yang terkait dengan testosteron yang rendah. Slide. Sedangkan kalau disfungsi ereksi, saya kira ini adalah salah satu gangguan male sexual dysfunction yang paling sering atau paling banyak sudah kita bahas. Definisinya saya kira kita semua sudah tahu, that this is a consistent inability to attain or maintain penile erection for satisfactory intercourse. While infertility, this may cause atau bisa berkontribusi dalam disfungsi ereksi yang psikogenik atau juga bersamaan dengan ada gangguan organik yang mempengaruhi baik disfungsi ereksi maupun disfungsi seksualnya. Apakah tools diagnostik yang kita pakai? Ini mungkin teman-teman yang banyak belajar di sini akan mengenal IEF 5 ataupun erectile hardness score. Slide. Etiologi di sini, apakah itu etiologi disfungsi ereksi organik, apakah itu iatrogenik, adakah gangguan hubungan yang berkaitan dengan disfungsi ereksi yang mungkin psikogenik, ataupun ansietas dan depresi, ini pasti pada pasangan dengan infertilitas, maka faktor psikis ini tidak bisa kita singkirkan. Slide. So, Jadi kalau pada pasangan infertilitas, apa yang harus kita lakukan untuk mengeksplorasi apabila ada tanda-tanda dari disfungsi ereksi ini? Pada dasarnya adalah suatu workup diagnostik atau pemeriksaan yang lengkap, sama seperti pada keadaan disfungsi ereksi lainnya. Kita satu fokus pada risiko kardiovaskuler, apakah ada komorbiditas, adakah sindroma metabolik, pernahkah ada pembedahan sebelumnya, penggunaan obat-obatan, misalnya baik obat-obatan medis maupun obat-obatan yang digunakan secara sosial, use of recreational drugs, istilah yang kadang kita dengar. Tentu saja merokok ini juga adalah faktor risiko infertilitas dan disfungsi ereksi. Apakah ada gangguan dalam keluarga, penggunaan obat-obatan. Dan yang terakhir ini mungkin yang paling penting dalam kita mengeksplorasi infertilitas terkait dengan disfungsi ereksi, bagaimana riwayat seksual dari pasien ini. Apabila kita bisa membuat hubungan terapeutik yang baik dengan pasien, kita bisa memahami ini, apakah tidak hanya pertanyaan yang organik di mana ada ereksi pagi hari, apakah bisa ereksi dengan stimulasi sendiri, ataupun misalnya ada partner seks yang lain, dan sejak kapan ini ada masalah dengan disfungsi ereksi. Slide. Ya, ini saya kira kuesioner juga kita semua sudah pernah lihat, IEF 5, slide. Slide. Ya, apabila ada disfungsi ejakulasi, maka yang perlu kita pertimbangkan atau eksplorasi apakah ada obstruksi, apakah ada kausa organik yang mendasari ini, mungkin trauma patah tulang belakang, apakah trauma pelvis, diabetes mellitus, dan Parkinson juga adalah penyakit-penyakit yang mungkin menyebabkan adanya gangguan ejakulasi. Apabila saya di sini sebagai ahli urologi menghadapi penderita yang mungkin akan menjalani tindakan operatif, apakah itu tindakan operatif di bidang onkologi, di sini contohnya RPLND, ataupun yang umum kita lakukan tindakan operasi pada prostat dan leher buli, misalnya tur prostat ataupun radikal prostatektomi. Ini adalah kondisi-kondisi di mana kita perlu mempertimbangkan apakah pasien ini masih memiliki keinginan mempertahankan fertilitasnya. Obat-obatan yang paling sering kita lihat dalam praktek sehari-hari ada alpha blocker, di mana ini juga tentu akan seringkali mengakibatkan retrograde ejaculation. Slide. Ya. Jadi ejaculatory dysfunction di sini, apakah di situ didapatkan aspermia, apakah tidak ada emisi sama sekali, apakah itu ejakulasinya masuk ke dalamnya kandung kemih, ataupun keluhan ejakulasi dini. Untuk ejakulasi dini, tentu karakteristik utama atau mendefinisikan keluhan ini adalah bagaimana pasien atau penderita itu bisa mempertahankan menahan ejakulasi selama berada dalam vagina atau intravaginal ejaculatory latency time. Ditambah dengan bahwa itu ada perasaan tidak bisa mengontrol dan mengakibatkan pasien ini mengalami distress. Ada beberapa angka-angka yang dipakai untuk sebagai panduan nih, kira-kira apakah ejakulasi dini sudah seumur hidup, di mana IELT tadi itu kurang dari 1 menit, ataupun ini sesuatu yang berkembang atau didapat oleh pasien, yaitu di mana latency time tadi bisa sampai dengan 3 menit. Slide. Nah, pertanyaan ini yang slide berikut ini menurut saya agak kontroversial. Ada satu kelompok ya dari Italia, mereka melihat kualitas sperma dan kemudian ini dibandingkan antara 4 kelompok, di mana satu kelompok ini azoospermia, kelompok yang paling kiri dilihat di sini, sedangkan kelompok yang paling kanan itu adalah kelompok yang tidak ada infertilitasnya. Di sini dikatakan bahwa orang-orang dengan azoospermia atau gangguan kualitas semen, maka ini didapatkan angka gangguan disfungsi ereksi yang makin meningkat. Slide. Yang kedua adalah untuk ejakulasi dini atau premature ejaculation. Di sini juga didapatkan bahwa orang-orang dengan azoospermia itu memiliki prevalensi dari premature ejaculation yang lebih tinggi dibandingkan orang-orang yang tidak infertil. Jadi ini menurut saya data ini sangat menarik, akan tetapi konteks dari data ini apakah ada faktor usia atau confounder yang lain masih perlu kita validasi dalam penelitian yang dilakukan oleh peneliti lain dan di dalam populasi yang lain. Slide. Tentu saja bahwa fertilitas ini dan fungsi seksual ini adalah suatu fungsi yang tersier dalam hidup, sehingga seringkali apabila orang itu mengalami gangguan kesehatan secara umum, apakah itu gagal organ, gangguan organ jantung, juga hematologi, misalnya di sini talasemia, atau gangguan neurologis, berbagai penyakit di sini bisa disertai dengan fenotipia atau keluhan klinis infertilitas. Ya, jadi ringkasan kami di sini adalah bahwa enggak kelihatan putus. Ya, bahwa sexual dysfunction ini adalah sesuatu yang sangat terkait dengan infertilitas, ya, saling berhubungan. Prevalensi kedua ini adalah sangat tinggi, di mana infertilitas bisa mendasari gangguan seksual, ataupun ini merupakan infertilitas terkait dengan gangguan kesehatan secara umum yang menjadi infertil maupun adanya disfungsi seksual. Obat-obatan ini bisa menjadi hal yang membantu kita ataupun hal yang menyebabkan terjadinya infertilitas maupun disfungsi seksual. Oleh karena itu, pada setiap laki-laki dengan infertilitas yang kita hadapi, ini harus dilakukan evaluasi yang komprehensif, baik itu apakah tidak hanya infertilitasnya, akan tetapi juga apakah adanya disfungsi seksual. Ya. Terima kasih. Saya kembalikan kepada moderator.
Thank you, Dr. Ayodhya, a very important talk. And welcome to Dr. Vinit Malhotra. I just see you. Namaste. And the second talk will be presented by Dr. Fikri Rizaldi, the microsurgical treatment of varicocele and male infertility. Dr. Fikri.
Thank you, Prof. Boleh screen share nggak? Good day, Dr. Vinit. I hope you're doing well there in Delhi. I also hope that we're doing well here in Indonesia, because the pandemic is not finished yet. Bisa screen share? Okay.
Good day to you too, and thank you for having me.
Yeah. Okay. Okay, so I start today. Thank you for the committee, Dr. Boy, Dr. Asra, to invite us in this Airlangga webinar conference series. So the topic right now is about microsurgery in varicocele and male infertility. Slide. So thank you for all of my teacher, especially Prof. Dodi, who teach me from the start with the microsurgery. All of my teacher in Indonesian Society of Urological Urology, Prof. Akmal, Dr. Ricky, Dr. Wirya, Dr. Bambang, Dr. Nur, Dr. Ponco, and also my teacher from India, Dr. Rupinsa and Dr. Vinet, Dr. Vijay Kulkarni also, and Masaki Kimura from Japan. Slide. varicocele slide. So with this varicocele definition, we've already known that it's abnormal dilatation and tortuosity in the internal spermatic vein that causes the abnormal sperm DNA quality, that causes testicular hypertrophy, and also impaired testosterone production and testicular pain. We will talk about sperm DNA quality with Dr. Vinet later. Slide. So we've already known that the grading system, grade 0 is non-palpable, but visualized only with the Doppler ultrasound. That makes it quite important for urologists to have a Doppler ultrasound in the outpatient clinic. The grade 1 only palpable with falsafa, grade 2 easily palpable but not visible, grade 3 is easily visible. You can see the pictures at the slide. Okay, slide. So how about the prognostic? The prognostic of the varicocele style and the response to the varicocelectomy. So if we found that the varicocele is grade 3, then the sperm concentration improves significantly after the microsurgery of varicocelectomy. So it depends on the grading of the varicocele. Slide. So this is important for preoperative that we check that the vein is the normal size is 1.5 millimeter. If it's more than that, then we can find that it's enlarged of the plexus pampiniformis. Slide. So how about the indication for operation? Of course, if it's documented infertility or abnormal semen parameters like oligoastenoteratozoospermia, or if it's if the patient is adolescent with reduced ipsilateral testicular size, also with hypogonadism and sometimes scrotal pain. But the scrotal pain is not all papers agree that it's indication for operation. Slide. So this is the operation of the microsurgery of varicocelectomy that we can do it with a microscope with enlargement of magnification 6 until 25. We also can use the ultrasound Doppler. The ultrasound Doppler is the right side, so we can check whether it's an artery or it's a vein. With the and that's 25. We can also see the lymph. So we didn't do any damage to the lymph or the artery. Slide. So how about the if we don't have a microscope or non-magnification? If we do the subinguinal varicocelectomy, the incidence of the hydroxyl formation and varicocele recurrence are larger if we do the operation without the magnification. Slide. So how about the incision? It could be inguinal, it could be subinguinal, or it could be subscrotal. I myself use the suprascrotal incision because it's easier for me, and after the skin and fascia, and we can see the funiculus spermaticus afterwards. But the disadvantage of subinguinal is it's quite difficult, and it should be experienced with microsurgical repair. Slide. So how many vein or artery during the operative? So overall it's 8.7, but we can find 8 until 11 vein per side. And also there is no significant difference between left or right. But the artery is 1 until 3. So we must preserve the artery using the Doppler ultrasound. Slide. So how about the post-operative check of the semen parameter? So in this slide, in this paper, that we can see that after 3 months, it's non-significant. So we can check the sperm 3 months after the varicocele repair, and we shouldn't check the sperm afterwards. Slide. So this is the latest paper by Dr. Poncho and Dr. Nurasid and Dr. Widi that the effect of the varicocelectomy microsurgery in the DNA fragmentation index is favorable after the repair. So if we find that varicocele, then we should do the operation to repair the sperm analysis. Slide. In this paper that we also can see that the sperm concentration, the motility and the morphology also getting better after the operation. Slide. How about the outcome? How about if the patient asks you if there is varicocele and the patient had the male infertility and the patient want to do the assisted reproductive technology. So in this slide that we can see that after the varicocele repair, the number of clinical pregnancy and number of live birth is better significantly after the operation or after the repair. Slide. So how about the other surgical like a vasovasostomy and vasoepididymostomy? Slide. So in this paper that if we find that the patient at vasectomy and the patient asks the urologist if whether it's to do the surgical reversal or assisted reproduction. In this paper that we can see that time to pregnancy was significantly shorter in vitro fertilization, 8 versus 60 months. So it depends on the couple's age. If the couple's age is probably more than 35, then probably for the woman, so it's better to do the IVF first. Then if the patient want to do other children, then the patient can do the surgical reversal. Slide. So how about the systematic review of the microsurgical vasostomy for vasectomy reversal? So there is no statistically significant in outcomes if it's before 10 years of obstructive interval. So 10 years is important. After 10 years, the pregnancy rate it's getting worse. And in this paper that we found out that there is no difference between single or multi-layer anastomosis. Prof. Dodi and me myself that it's better for us to do the multi-layer anastomosis, but this paper said no significant difference for vasovasostomy outcome. Slide. So this also had the information if it's the obstructed interval is more than 15, then it's significantly lower clinical pregnancies for those who seek vasovasostomy reversal. Slide. So how about the impact of the obstructive interval and sperm granuloma? This paper also said that if it's before 15 years, there is no difference in pregnancy rate, 89, 82, and 86. But after 15 years, there will be a significant decrease for the pregnancy rate. Slide. This paper also from Professor Dohle from Rotterdam. How about the fascial patency? This paper from 2011 that from Professor Dohle said that it seemed to be equal to fascial patency for 1-layer and 2-layer vasovasostomy. The most important predictors is not the 1-layer or 2-layer, but the surgical skill of the operator and the characteristic of intraoperative fascial fluid. So we can check the fascial fluid during the operation. Slide. So how about the 1-layer and 2-layer? This is the second paper that there is no difference in patency between 1-layer and 2-layer, but it's shorter in 1-layer group. in my opinion, that 1 layer or 2 layer, probably it's different 30 minutes, I think. So 2 layer is better in my opinion, but this paper said no difference in patency. Slide. Probably we can ask Dr. Finet how about his experience during the vasostomy and vasoepididymostomy. Slide. So how about the vasoepididymostomy, the meta-analysis? So in this paper that we can see that if we do the vasoepididymostomy, it should be on the bilateral side. So almost all the papers said that it's bilateral to do the vasoepididymostomy, not only unilateral to get the results better. Slide. How about the place to do the vasoepididymostomy? So we can see that it favorable to the corpus or cauda within 1.1% better to do the corpus side. Slide. From this meta-analysis that we can see also that the sperm motility is better in the post-operative. So vasoepididymostomy is operation of choice from obstructive azoospermia, especially from vasectomy reversal. Slide. How about the microsurgical epididymal sperm aspiration? Slide. We can see this video about the microsurgical sperm aspiration during the workshop, but this year we had the pandemic and we don't have the workshop for this. So sperm retrieval is, there are many choices for sperm retrieval. We can see that the easiest one is percutaneous epididymal sperm aspiration, local anesthesia, it's a short time, but the indication is only for obstructive azoospermia. How about if we cannot find the sperm from PESA? Then we choose afterwards. We can see that we can do the open epididymal fine needle aspiration until the testicular sperm extraction, or also the microsurgical testicular sperm extraction. Slide. In this paper that we can see that if we cannot find it in the percutaneous epididymal sperm aspiration, we can do the open epididymal fine needle aspiration to find out what is where is the place to do the open epididymal fine needle aspiration. Sometimes we can find a good sperm there, but if cannot find, then we choose other choice like testicular sperm extraction. Slide. In this case, from non-obstructive azoospermia, we choose the micro testicular sperm extraction with a higher success rate, but low risk and complication. And we can we will have a tricks to increase the success rate in the micro TC. Slide. So how about the indication? Of course, the microsurgical epididymal sperm aspiration is for the obstructive azoospermia or ejaculatory duct obstruction with the suggestion of normal FSH and testosterone, or suggestion of obstructive azoospermia. Slide. So in this video, we can see that microsurgical sperm aspiration is quite easy to do, but there's a problem that we cut a lot of track to within the epididymis. So probably after that, if the patient want to do the IVF more, or IVF second IVF, then probably we need to do a MESA later again. Slide. How about the microsurgical testicular sperm extraction? Slide. So in this operation, that it's indication for non-obstructive azoospermia. But how about the prognostic? The prognostic is higher if the testicular volume is within normal limit with a cutoff of 11 cc of milliliter. Slide. And how about the fresh and also salvage micro TC? That there is a positive correlation if we find out that the patient had a high FSH level and the the relation is getting decreased to get the sperm, and how we can find the sperm. Slide.
Dr. Fikri, 3 minutes left.
Okay, this is the last slide, Prof. Thank you. So this is the beautiful paper from Paul J. Turek. We discussed this paper with Dr. Poncho and the last INASAO meeting that after the biopsy, it's the sperm is retrieved in all cases if we find out the sperm in the biopsy. Slide. So Paul J. Turek give the explanation that if we find out the sperm in the biopsy within numbers, then we can find the sperm after the biopsy with the micro TC. Slide. So in this case, that if the biopsy has find out the sperm with the 8, 12, and 13, then most of the patient to do the micro TC will find out the sperm in there. So it's better for the operator to find out the sperm after the biopsy. Slide. I think that's all of the slide. We will come you to the next Fiesta and next INASAO workshop if the pandemic is over. I think that's all, Professor Dodi. Thank you.
Thank you, Dr. Fikri, for the very nice presentation. And before we go to the next speaker, I'd like to share with you the history of the long friendship of andrology and urology in Surabaya. I will share you the slides. Sorry. May I share my slide first? Sorry, yes. Okay. This is a long history of our friendship, andrology and urology in Surabaya. And this is the persons, our teacher, Professor Arif, Professor Wijoseno, and we have Professor Sabila, Professor Wimpi, Professor Alex Pangahila, Dr. Oka, Dr. Wirya, I suppose he's also available here, and others, and Dr. Oki and myself. And we are very proud that we have the friendship until now, especially in the field of reproductive medicine and sexual medicine and the reproductive technology. Dr. Oki Hinting is a pioneer of IVF and andrology in Indonesia and also world renowned. Dr. Oki, please.
Thank you, Prof. Dodi. Good day, Prof. Dodi and other friends. Thank you for the committee for inviting me, and as mentioned by Prof. Dodi, we are very good friends. Today, I will talk something about how we could find the sperm for ART or for ICSI, and they will ask also how we do it. So I will explain you a little bit further. My slide is in English, but probably I will talk in Indonesia because most of the participants are Indonesian. So why the sperm should be prepared? This is slide over 30 years. The reason is seminal plasma contain or factor impair fertilizing capacity. So in seminal plasma, you have a factor that impairing fertilizing capacity of the sperm. In seminal plasma, you have microorganism, white blood cell, prostaglandin. And in seminal plasma, you have motile sperm. It is more efficient to do with motile sperm. And while you are doing sperm preparation, you induce capacitation, you induce process to do the capacity of fertilizing ability. So the objective of the sperm preparation is to separate motile spermatozoa from seminal plasma with maximal recovery and minimal damage. So the ideal teknik yang ideal untuk melakukan preparasi sperma itu kita harus cepat, mudah, dan efisien. Kita bisa mengisolasi sebanyak mungkin sperma, mendapatkan recovery semaksimal mungkin, tidak menimbulkan kerusakan pada sperma, yang pada akhirnya kita juga melihat kita meningkatkan juga spermatozoa dengan normal DNA damage, kita menghilangkan spermatozoa mati dan sel lain, kita menghilangkan bahan-bahan yang toksik di seminal plasma. Ya. Jadi teknik yang umum digunakan untuk pencucian sperma adalah swim up. Ya. Ini teknik yang sudah sangat lama. Kita tahu bahwa pencucian ini sudah ditemukan oleh Chang dan Austin tahun 51. Jadi swim up dari semen yang paling gampang, kemudian washing dan swim up. Ini yang masih dilakukan oleh orang, washing, swim up. Kemudian yang saat ini kita lakukan adalah density gradient. Tadinya dengan percol, tetapi karena beberapa masalah dari percol, kemudian diganti dengan colloidal silica. Kita menggunakan side lane coated colloidal silica. Ya. Ada juga yang menggunakan colloidal yang non silica. Jadi washing swim up itu sangat sederhana. Sperma kita campur dengan medium, kemudian kita sentrifuge 2 kali. Tujuannya sentrifugasi ini overlayernya kita ambil, jadi seminal plasmanya kita buang. Jadi tinggal pelletnya. Pada waktu di pellet ini, kemudian kita biarkan dia selama 30-60 menit, 37 derajat. Spermatozoa yang motil akan naik ke atas. Spermatozoa yang naik ke atas ini kemudian kita tangkap, bisa kita gunakan untuk IUI atau IVF atau untuk ICSI, ya, bisa kita gunakan. Sekitar tahun 90-an kita mendapatkan suatu bahan yang sangat bagus. Kerugian washing swim up tadi, pada waktu dia di dasar tadi, sel spermatozoa bercampur dengan bahan-bahan yang bisa toksik untuk spermatozoa. Nah, kita menggunakan larutan density gradient. Kita mempunyai larutan yang namanya percol. Percol ini adalah larutan polyvinyl pyrrolidon yang tidak bereaksi dengan air, dan tergantung dari kadar percol ini berapa, makin padat, makin dekat molekulnya, saringannya makin kecil, makin longgar, makin besar saringannya. Sehingga semen kita taruh di atas 2 cc, ada 2,5 cc, 2,5 cc. Kita putar spermanya dalam waktu 20 menit itu, sperma yang motilitasnya biasanya motilitasnya bagus dan bentuknya bagus akan terus ke bawah. Sperma yang bentuknya jelek akan tersangkut di tengah sini. Sel-sel leukosit dan sebagainya akan ketinggalan di atas. Sehingga kita bisa mendapatkan sperma yang bagus yang jatuh ke bawah ini. Setelah itu supernatanya ini kita buang, kita resuspensi dengan medium pencucian, dengan washing medium. Kemudian kita biarkan 5-10 menit biar sperma motilnya naik ke atas, kemudian kita tangkap yang dari percol ini. Ya. Jadi kita saat ini sebagian besar kalau orang mengirim untuk inseminasi atau lainnya, kita melakukan yang density gradient ini. Ya. Sampai tahun 2000-an kita sudah happy dengan percol ini. Kemudian timbul masalah sekitar tahun 2000, adanya endotoksin di percol. Dan percol ini digunakan hanya untuk uji-uji yang in vitro, bukan untuk in vivo. Dan percolnya sendiri tidak mau melakukan penelitian. sehingga perkol ini harus diganti. Ada tes-tes yang digunakan, ya. Dan pada tahun 2000, sekitar tahun 2000-an itu kita beralih ke sil select, ya, colloidal silica. Kita menggunakan sil select dan kita cek semuanya bagus dengan sil select, tidak ada perbedaan. Kita bandingkan dengan perkol, kemudian kita berubah dengan sil select, ya. Dan kita juga melihat pada tahun yang sama, sekitar 2010, banyak penelitian yang melihat kemampuan dari pencucian sperma ini untuk melihat penurunan DNA fragmentasi. Dan setelah pencucian verkol, kalau kita lihat yang di bawah ini, DNA fragmentasinya ini pada sil select ini, kita melihat penurunannya itu 30-50% DNA fragmentasi. Jadi saat ini untuk kasus-kasus IUI atau konvensional IVF, kita menggunakan density gradient dengan sil select ini, ya. Dan kita menggunakan ini sperma bisa yang normal, bisa juga yang jelek sampai dengan 5 juta, kita tetap menggunakan ini, ya. Bagaimana untuk preparasi sperma dengan kualitas sampel yang jelek, ya? Kita bisa menggunakan density gradient, tapi volumenya kita perkecil, namanya mini density gradient. Kita bisa menggunakan migration gravity sedimentation, nanti saya jelaskan. Tetapi kita saat ini banyak melakukan yang kita sebut dengan side migration technique, ya. Jadi mini density gradient sama dengan perkol tadi, tetapi volumenya kita perkecil. Kalau tadi 2,5 cc, yang ini hanya setengah cc. Volumenya lebih kecil sehingga mendapatkan cairan lebih banyak. Pada sperma-sperma yang jumlahnya sedikit, motilitasnya rendah, spermanya itu sangat sedikit. Kadang-kadang kita sangat sulit mendapatkan sperma. Kalau kita menggunakan perkol yang besar, itu hilang spermanya. Kita nggak ketemu, ya. Sehingga kita harus kecilkan, ya. Atau kita menggunakan migration gravity sedimentation. Ini adalah tabung yang dua, ini satu yang besar, ada yang satu yang kecil di sini. Kemudian sperma kita taruh di luar ini, kita tutup dengan medium. Sperma ini akan bergerak ke atas, tetapi setelah 60 menit karena dia terlalu lelah, sperma ini akan turun ke bawah. Dan teknik ini bisa kita gunakan sampai dengan 6 jam, 3-6 jam. Kita tangkap sperma ini yang di bawah, ya. Tetapi kita melihat kalau sperma yang sangat sedikit, sperma yang dari TC yang sangat sedikit, kita sulit sekali menangkap sperma itu, maka kita memerlukan bidang yang horizontal, ya. Jadi kita mulai melakukan ICSI di sini tahun 1995, sudah 25-26 tahun yang lalu bersama Prof. Dodi juga, dan kita mulai melakukan penelitian-penelitian pada penangkapan sperma ini. Dan tahun 1999 itu waktu Profesor Skill datang, kita menunjukkan cara kita dengan horizontal ini, dan kami diminta untuk membuat publikasi dari yang kita sebut side migration technique, ya. Jadi apa yang kita lakukan, kita buat medium, di tengah itu ada medium 150 mikroliter, di tepi kita buat medium kira-kira 7 mikroliter, kita hubungkan masing-masing itu. Sperma kita washing swim up 1 kali, kita taruh di tengah. Dengan kondisi yang horizontal, dia akan bergerak ke samping. Sperma yang di samping itu yang bagus, itu yang kita tangkap, kita pakai untuk ICSI, ya. Jadi itu yang kita gunakan. Teknik ini banyak mendapatkan modifikasi, dan modifikasi yang terakhir itu sebetulnya pada dasarnya sama, hanya tetesannya tidak menggunakan platelang lain, disebut horizontal sperm migration. Jadi sampai sejauh ini kita melakukan teknik untuk pencucian sperma dengan cell select sedimentation, density gradient sedimentation, dan untuk ICSI kita menggunakan side migration teknik. Ya. Sekarang saya akan membicarakan bagaimana kondisi-kondisi khusus kita melakukan untuk ICSI, ya, azoospermy, spinal cord injured-man, retrograde ejaculation, cryptozoospermy, necrozoospermy, iDNA fragmentation, dan frozen spermatozoa. Ya. Jadi sejarah yang lama, ini maaf slide yang lama sekali dari Prof. Dodi, kita menggunakan lokal anestesi, baru akhir-akhir ini ada pasien yang minta general anestesi walaupun mungkin tidak sakit atau bagaimana, kita melakukan PESA, kita coba multiple attempt, dicoba di satu sisi, nggak ketemu, pindah ke yang lain. Kalau nggak ketemu, baru kita lakukan TC. TC kita ambil dari testis. Tapi kalau PESA sudah ketemu, kita berhenti di PESA. Ya. Sampai dengan 2019 yang lalu, kita melakukan sudah hampir mendekati 1000 ya. Ini sudah 943 sampai saat ini sebulan kita rata-rata melakukan sekitar 10 ya. Jadi kalau sekarang ini kira-kira sudah 1000 kita melakukan ya. Angka kehamilan yang epididimal lebih tinggi 54%, kalau yang testikuler itu lebih rendah ya, hanya sekitar 30% per siklusnya ya. Jadi kalau kita lihat angka-angka kehamilan mulai pertama tahun 96 kita melakukan ICSI tahun 95 dan kita lihat tahun 2019 kalau dulu angka kehamilan kita sekitar 30%, saat ini angka kehamilan kita ini sudah sekitar 50% dari PESA, TC dan ICSI ini ya. Jadi itu dari kasus-kasus azoospermy ya toh. Pada pasien-pasien dengan spinal cord injured-man kita punya beberapa kasus tetapi tidak terlalu banyak. Ada orang yang stroke kita ambil. Zaman dulu ada orang yang mungkin Prof. Dodi masih ingat zaman dulu ada dokter yang senior yang setelah operasi prostat spermanya nggak bisa keluar, kita juga mengambil dari testis ya, dari pasien-pasien spinal cord injury. Pada awalnya kalau kita ikuti literatur, ini publikasi yang kita lihat tahun 2013, pada waktu tahun 2006 mereka mencoba yang SSR dengan yang dikeluarkan electro ejaculation, yang elektro lebih bagus. Tapi saat ini 2013 itu angka kehamilannya, fertilization rate-nya, sperm retrieval dibandingkan dengan electro ejaculation ya, pengambilan dari penis itu sama angka kehamilannya ya. Jadi saat ini kita juga bisa melakukan pada spinal cord injured man ya. Kasus-kasus retrograde kita juga melakukan, kita tidak membuat publikasi, tetapi paling tidak kita sudah melakukan 5 atau lebih kasus-kasus dengan retrograde ejakulasi. Jadi urinnya itu kita alkalin malam harinya dengan sodium karbonat, ya, lalu dia harus kencing sebelum masturbasi, kemudian setelah dia kencing, dia melakukan masturbasi, setelah masturbasi, urinnya kita tampung, dan urin ini kita sentrifus, dan kita bisa mendapatkan sperma. Sperma ini kita pakai untuk preparasi, ya. Kita taruh di side migration teknik tadi, ya. Sekarang ini dalam 5 tahun terakhir, terutama 3 tahun terakhir ini, kami sendiri ada kasus-kasus yang akan kami lakukan TC. Saat ini pun ada pasien yang distimulasi, pasien-pasien yang kriptozoospermi. Jadi pasien ini datang dengan kadang-kadang azoospermi, kadang-kadang spermanya di bawah 0,1 juta. Kalau kita tanya di sentrifus, ketemu 1-2 sperma kadang-kadang tidak bergerak. Jadi kita sebut kriptozoospermi. Dan pada kasus kriptozoospermi ini hasilnya lebih bagus kalau kita ambil itu dari testis. Jadi diambil dari testis, kemudian kita lakukan ICSI seperti biasanya. Begitu juga pada yang mikrozoospermi, spermanya keluar, jumlahnya cukup, tapi motilitasnya nol atau hampir nol, ya tidak ada. Ini lebih bagus. Jadi kami juga sudah melakukan ini. Ada dari seorang pilot, dari apa kita nggak tahu penyebabnya, spermanya ini bisa mati semua, ya. Kita lakukan pengambilan sperma dari testis, ya. Kemudian ini ada publikasi di mana kasus-kasus dengan DNA fragmentasi yang tinggi itu kita lakukan juga TC, kita ambil, kita injeksikan. Menurut publikasi ini hasilnya lebih bagus, ya. Kami ini masih belum yang high DNA fragmentation ini, tapi kasus-kasus yang spermanya sangat jelek, kita anjurkan untuk kita lakukan TC, kemudian kita injeksikan, ya. Dan kasus-kasus frozen sperm, ya, itu juga sangat tinggi saat ini, atau dari waktu ke waktu setiap bulan kami ini mendapat pasien-pasien yang setelah orang-orang mendapat terapi, kemoterapi onkologi atau radiasi, ya, gonadotoksik, ya, dan sebagainya, atau orang yang selama ART mengalami kesulitan. Kalau kita mau ART, kita tahu orangnya bilang, oh sulit, susah ini mengeluarkan, pada harinya susah. Kita melakukan freezing dulu pada sperma, ya. Kita juga menghindari repeated surgical sperm retrieval. Kalau kita melakukan PESA atau TC, kalau kita melakukan PESA, terutama dapat lagi pasiennya. Kalau spermanya bagus, kita freeze, sehingga lain kali dia tidak usah mengulang PESA lagi, ya. Dari waktu ke waktu, Prof. Dodi juga mengundang kita untuk kita melakukan freezing pada pasien-pasien yang mau vasovasostomi atau vasoepididymostomi, ya, atau sperm banking, ya. Angka-angka kehamilan cukup bagus pada pasien-pasien dengan frozen sperm ini, ya. Angka kehamilan di kita sekitar 50% juga, ya. Jadi itu kasus-kasus di mana koleksi sperma itu membutuhkan teknik khusus yang harus kita tangkap spermanya, kita tangkap, kita suntikkan ke sel telurnya dan menghasilkan embrio untuk ICSI, ya. Selanjutnya saya akan berbicara tentang bagaimana kita menseleksi sperma untuk ICSI ini, ya. Sedapat mungkin kita melakukan pencucian sperma dan mendapatkan spermatozoa yang motil. Kalau bisa morfologinya normal, kita gerakkan. Tetapi bagaimana apabila kita melakukan TC, kemudian kita lihat hampir semua sperma tidak bergerak, ya. Tapi kita ingin membuktikan bahwa sperma itu bergerak, ya. Ada banyak cara, bisa dengan host test, diberikan larutan hipoosmotik yang menggelumbung, diberikan bahan-bahan kimia untuk menggerakkan. Tetapi yang cara paling yang sederhana yang kita lakukan sekarang itu adalah kita melakukan sperm tail flexibility test. Jadi ekor sperma yang tidak bergerak itu kita geser dengan jarum ICSI. Kalau dia tahu-tahu bergerak sedikit, goyang-goyang sedikit, oh ini hidup spermanya, ya. kita melakukan yang sperm tail flexibility test ya. Ada yang menggunakan laser dan sebagainya. Kita menggunakan sperma yang kita gerakkan sehingga tahu sperma ini bergerak, kita lihat bentuknya normal, semuanya normal, kita lakukan untuk ICSI. Nah, ini ada satu teknik yang banyak sebetulnya akhir-akhir ini diributkan, tetapi sebetulnya di dunia barat ya sudah banyak ditinggalkan ya. Jadi pada tahun 2002 ya, Baltov dan kawan-kawan itu melakukan publikasi tentang IMSI ya. Dia melakukan injeksi sperma dengan high magnification. Jadi spermatozoa itu dibesarkan 6.000 kali. Kalau kita melakukan ICSI, itu kita melakukan hanya pembesaran 400 kali. Ya. Jadi Baltov, lalu ada sarjana Perancis, Meneso, ya, melakukan publikasi 400 sampai 6.500. Sekitar tahun 2002 sampai 2010 itu banyak yang mencoba IMSI, ya, namanya IMSI. Tetapi nyatanya teknik ini sudah hampir 20 tahun tidak berkembang dengan memuaskan, hasilnya juga sama saja. Morfologi yang kelihatannya nggak normal dengan IMSI itu, ada vakuol yang besar, itu juga kemungkinan fisiologisnya normal, waktunya lebih lama, biayanya lebih mahal, dan akhirnya pada tahun 2012 kita itu mengadakan pertemuan, beberapa center di Eropa sudah meninggalkan, di Malaysia juga meninggalkan, ya. Akhirnya evidence base pada tahun 2020 ini menunjukkan bahwa tidak mendukung atau menghindarkan IMSI ini, ya. Tidak ada kenaikan pregnancy rate, tidak ada kelainan lain-lain, sehingga kembali orang tetap melakukan ICSI hanya dengan 400 kali itu saja, ya, dari yang ICSI ini. Jadi itu ICSI, kemudian ada teknik lain, ya, ada bahan di mana ada hyaluronan. Bahan hyaluronan ini katanya bisa lengket dengan sperma. Sperma yang bagus akan dilengkapi hyaluronan, dan yang dilengkapi hyaluronan ini yang kita pilih untuk kita ICSI-kan. Sama data-data dengan IMSI tadi, PICSI dan ICSI ini angka kehamilannya tidak berbeda, semuanya biochemical pregnancy dan sebagainya tidak ada berbeda, sehingga PICSI ini ditinggalkan, ya. Jadi bagaimana kita memilih sperma, tetap kita menggunakan ICSI dari sperma yang bergerak, dari yang terbaik kita angkat, ya. Selanjutnya saya akan berbicara juga sedikit mengenai sperm sorting. Kalau kita nggak ketemu sperma, ya, kalau kita melakukan PSA-TC tidak ketemu sperma, kita lihat sel-sel di sini, ya. Ada sel-sel yang kecil-kecil ini, round spermatid, ini kita injeksikan, ya. Dan sampai saat ini hasilnya sudah ada kehamilan, tapi angkanya rendah sekali, kira-kira 3-10%, sedangkan ICSI 10-40%. Jadi yang dari round spermatid ini rendah sekali. Kita melakukan, tetapi sampai saat ini ada yang biochemical pregnancy, tetapi tidak ada yang hamil sampai spontan. Data-data dari Eropa pada S-ray tahun ini dilaporkan juga kehamilannya di bawah 10%, sekitar 9% angka kehamilannya, ya. Saya akan berbicara juga sedikit, hanya beberapa slide, bagaimana kita memilih sperma ini. Ada metode yang dikenalkan dengan sorting, bagaimana kita memilih sperma. Sperma yang kita pilih ini kita gunakan untuk IVF atau ICSI, ya. Ada sperm sorting, preconceptional sex selection. Jadi tahun 90 ada Genetik dan IVF Institute melakukan metode dengan flow cytometry. Jadi sperma yang kromosomnya X dan Y itu muatan listriknya berbeda. Dengan flow cytometry mereka bisa memisahkan yang X dan Y ya. Dan hasilnya itu sekitar 87% untuk X, 75% untuk Y. Dan kalau kita lakukan IVF ICSI, hasilnya 93% X, 85% males ya. After sorting for Y, maaf itu salah, sorting for Y ya. Sorting for Y ya. Angka kehamilan itu angka abortusnya ya. Ada teknik-teknik, dua teknik yang saya kemukakan lebih lanjut adalah bagaimana kita juga bisa mensort sperma ini kita pakai untuk kita lakukan ICSI. Saat ini kita sedang menunggu angka-angka keberhasilan ini, kita melakukan microfluidic sperm sorting. Jadi ada tabung besar yang sebelah kiri ini, kemudian kita taruh sperma di sini, maka sperma itu akan bergerak ke kiri di sini. Di sini ada medium yang cair, sperma yang bergerak akan bergerak ke atas. Yang di atas ini kita tangkap ya. Kita taruh di sini. Sebetulnya ini yang mirip-mirip side migration itu ya. Cuma ini kita tangkap di sini, kita masukkan ke sini ya. Ini teknik lain, microfluidic sperm sorting. Kemudian ada yang sangat menarik sekali, yaitu magnetic activated sperm sorting ya. Sejak tahun 2012, 2013 baru dalam 10 tahun terakhir ini. Jadi spermatozoa itu sebelum kita cuci, spermatozoa itu kita campur dengan suatu larutan annexin V conjugated magnetic sperm ya. Jadi ini bahan kimia yang bisa berikatan dengan sperma yang telah mengalami apoptosis. Jadi sperma yang mengalami apoptosis itu berikatan dengan ini, kemudian sperma itu kita lewatkan ke kolom ini ada magnetnya, sehingga sperma yang berikatan itu akan lengket di dinding, dan sperma yang lewat adalah sperma yang tidak apoptosis ya. Dan datanya sperma yang tidak apoptosis ini DNA fragmentation indexnya sangat tinggi. Dan ini kita gunakan untuk ICSI ya. Kendala dari Max ini cuma satu, yang paling mahal karena harga reagen ini untuk satu reaksi pencucian ini sangat mahal. Kalau di Indonesia sekitar 4 juta rupiah hanya untuk memisahkan ini untuk satu sperma ya. Jadi saya kira sampai di sini presentasi saya. Jadi sperma harus dipreparasi untuk memisahkan spermatozoa motil dari seminal plasma dan debris lain. Pada umumnya density gradient ini adalah teknik yang baik. Untuk sperma preparasi, untuk poor quality sample kita menggunakan side migration teknik. Banyak cara-cara koleksi untuk ICSI, termasuk cryptozoospermi dan lain-lain. Spermatozoa motil dengan morfologi yang baik, itu yang bagus kita injeksikan ke oosit ya. Kalau tidak ada motile sperm, beberapa tes kita gunakan untuk mendapatkan sperma yang viable ya. Spermatozoa yang round spermatid bisa digunakan untuk apabila tidak ditemukan dan menghasilkan kehamilan sudah ya. Teknik-teknik selanjutnya including microfluidic sperm sorting dan magnetic activated sperm sorting masih dipelajari lebih lanjut. Saya kira cukup sekian Prof. Dodi.
Thank you, Dr. Oki. Very interesting that we know that he did a lot of work after we retrieved the sperm. And now we invite Dr. Vinit Malhotra. The question is about the sperm DNA fragmentation. When and why, the indication. We are very eager to know from you, the expert, and we know your reputation is well known. Please, Dr. Finet.
Thank you so much, Professor Lodi, and I would like to thank the committee for having invited me for this conference of 37th Fiesta Urology. And let's start with I need to be allowed screen sharing. Yeah, okay, just a moment. I think, can I be assisted for screen sharing? Because I think I'm having problems with my screen sharing. If the committee can share my presentation then. So we're very interesting talks we've had today, and we will talk on one of the aspects which has been mildly covered, which is sperm DNA fragmentation test. Now we'll hear this term time and again in regards to cases which do not get sorted by simple maneuvers. They don't have either natural conception or do not have a simple IUI or an IVF or an ICSI success and are recurrent failures. And time and again, you listen to this term of what the sperm DNA fragmentation test results were. Next slide, please. Next slide, please. Slide. This is a image that I picked up from the blog site on the internet, and this is something that I like to present in my first presentation because this is what the woman goes through and her feelings, and I really like to present this first up because usually it's all the woman's trouble and nothing for the man, and somehow in some situations those simple sperms or single sperms or few sperms become very important when the IVF checklist does not work for her. Next slide, please. So what we will discuss today is what is the definition of sperm DNA fragmentation, what type of tests are available, what are the ones that we would like to use, what are the current recommendations based on guidelines, and what are the best practice expert guidelines on when and whom to test and how to treat. Next, please. Why all of this? Now, the problem is that when you use conventional semen analysis as a surrogate for male fertility, it's not very good. And we found that this does not always correlate with ART outcomes, reproductive outcomes. Next slide, please. The function of sperm is to deliver intact DNA into the oocyte for viable pregnancy. And this can exist, the chromatin can exist either in a bound form to protamen or histone, the loosely bound form. And infertile men have been found to have a higher sperm histone to protamen ratio. That's the basis behind where we come from when we are talking about DNA fragmentation. Next, please. So sperm DNA fragmentation refers to denatured or damaged sperm DNA that cannot be repaired. Now let's also understand that sperm by itself does not have an ability to repair itself. It's either the oocytes or the early embryo which may repair sperm DNA damage, but the sperm itself does not have the ability to repair itself. Next, please. So there may be reasons as to why DNA fragmentation may be increased, which may be intrinsic factors or extrinsic, which means there could be protamen deficiency. There could be excessive ROS production within the body. Increased age is a factor for causing higher DNA fragmentation. Or there could be external factors. We've seen a beautiful paper on varicocele, which spoke about the effect of varicocele testicular hyperthermia leading to increased sperm DNA fragmentation, toxins, smoking, inflammation, infections. Next, please. So based on this, we'll see a variety of factors: varicocele, diseases, infection, age, heat stress, defective protamination, whether it's radiation, chemotherapy, Unknown factors also, all of these resulting in sperm DNA damage, which may affect fertilization or may result in early miscarriage, either with natural conception, IUI cycles or ICSI cycles. If there is DNA repair, then we are going to see normal embryo development. If there is no DNA repair, you're going to either result in fertilization failures, you're going to have early miscarriages, or miscarried pregnancies, or sometimes the concern is also defects in offspring. Next, please. So when will you like to do DNA fragmentation index tests? So if you have history of risk factors, unexplained male infertility, varicocele, history of urinary tract infections or seminal infections, history of such risk factors such as obesity or smoking, age greater than 40 years, repeated IUI or IVF failures, or recurrent pregnancy loss. All of these become indications for measuring DNA fragmentation or doing the DNA fragmentation tests in men. Next, please. There are two variety of tests that we see, those that detect actual DNA strand breaks, which are called direct tests, or those that measure the susceptibility of DNA to denaturation, which are called indirect tests. Now, the direct tests include tunnel, comet, and in situ Nick translation. Now, unfortunately, because they require complex equipment, flow cytometers, there may be a restriction of cost and expertise to be doing these tests. The indirect tests are far more commonly performed. So whether you have the SCSA or the halosperm or the sperm chromatin dispersion test or dye-based test, more commonly, so halosperm or SCD is the most commonly performed test since it is simple to perform, it's inexpensive, it can be done in the IVF lab itself. So it's essentially the most common test on which most outcomes have been assessed. Next, please. Now, when you look at various advantages and disadvantages of tests, the tunnel stands out as one of the accurate tests because it can be performed on few sperm. It can be performed using a small tabletop flow cytometer. With all the tests, there is a problem of thresholds. Now, all centers which are using any of the DNA fragmentation tests as hallmarks are using different protocols, assay protocols, and are using different thresholds. So you don't have a standardization of threshold for a particular test for a particular center. Each center will have its own methodology. And these are expensive. There are very few centers in India which actually use tunnel as the test for DNA fragmentation. Next, please. Comet is a test which is very popular in the UK, but again, it is expensive. It's sensitive. Again, it can be performed on few sperm, and it is a sensitive test, but it requires imaging software, wearable assay protocols, and unfortunately expensive, so not commonly performed. Next, please. Now, SCD or halosperm is the most commonly performed test which is available. It's very easy. You can use bright field microscopy and see it. You can use a few sperms to do it. You usually do it with 100, 200 sperms available in the field, and you can use that test. It has a very high inter-observer variability. And that's one of the drawbacks of this test. When you compare the results of halosperms between two centers, it's so dependent on the observer that you can have wide variation from the same neat semen sample. Next, please. The SCSA is a far more accurate test. It needs far more sample for assessment of sperm DFI. So many cells are rapidly examined. And when you do this as a, there is not much center or observer variation here. So it's something which allows a fairly accurate data maintenance. And so you can do multicentric studies which will have similar outcomes and can be assessed objectively. Again, the equipment is expensive. This is a flow cytometer based test. And there can be qualitative decisions which will result in calculations. There is, again, a difference in threshold at different centers. And that's the problem where you put different cutoffs as to what is significant and what is insignificant DFI. Next, please. So if you look at this chart, what you will see is when you use these tunnel, comet, SCSA or SCD, which are the most commonly used tests, the cutoffs are extremely variable between various studies that have been used. So whether you have a 10 to 20% cutoff for the tunnel to a approximately 40 to 50% for the comet, and an average of about 20 to 30% for the SCSA or the SCD. That's been the difference in the kind of cutoff ranges that you've seen from a variety of cycles. You've also studied it with regards to different pregnancy outcomes, whether there is a differentiation that it makes with regards to natural pregnancy, whether it affects the IUI pregnancy, IVF or ICSI. Most data that you will see has come to a conclusion that you can predict affection of natural conception and some degree of affection of IUI pregnancies. There is very little impact of DNA fragmentation on ICSI outcomes. Next, please. So you have several questions to answer, and unfortunately, we've not reached these answers yet. There are a variety of methods available to assess sperm DNA fragmentation. We do not know which is the most accurate test. Methods differentially assess the DNA fragmentation. Unfortunately, if you look at this, they don't determine the etiology of damage. They are only able to say that DNA fragmentation has happened, and they are able to predict or give a percentage DNA fragmentation, but they are not able to label it as a particular cause and even cause and effect of to relate with infertility. There is no standard assay protocol method. Every lab has its own individual method. Even with the same machine, you will have different assay protocols, and cutoffs are different. There is a variability which exists in terms of results between lab to labs, especially with tests such as HaloSperm. So if you look at our country, and I'm talking about India in terms of what we are using, you'll find HaloSperm to be the most common. Almost 80 to 90% of all results in terms of DNA fragmentation are based on SCD or HaloSperm, and a few labs use SCSA. Tunnel is used by only probably one or two labs, or in the research labs where only academic interest studies are done. Next, please. So what are the recommendations? Next, please. Now, AUA has not come out with recent guidelines for the use of DNA fragmentation. It remains the same. So these guidelines, which came in 2011, are also currently followed, and they say there is insufficient evidence to support routine use of DNA integrity testing. Next, please. ASRM guidelines have also not changed from their 2015 guidelines, which show that they do not support a consistent relationship between abdominal DNA integrity and reproductive outcomes. There is more study that we need to do with this. Next, please. The EAU guidelines mention the effect of increased DNA fragmentation, reducing the chance of natural conception and increasing the risk of pregnancy loss. Though they have mentioned that we must adhere to the 2010 WHO manual for semen analysis, and that does not mention sperm DNA fragmentation as one of the routine tests that we need to do for assessment of male reproductive potential. Next, please. So essentially, what do we come to? We come to what is the expert guideline. This is an excellent article which I will recommend to anybody who wishes to get a gist of where we are in terms of sperm DNA fragmentation. There is a huge number of authors who are clinically working on DNA fragmentation who've participated in this article. And it's a kind of an expert guideline for clinicians. Next, please. Is it a primary test for evaluation of the infertile male? No, we do not use it as a primary test. This is advanced sperm function test, and it has indications, which means we will use it for idiopathic or unexplained male infertility. We will use it in couples that have had recurrent pregnancy loss, ART failures, failures of fertilization, failures of natural conception, and where risk factors exist, as mentioned previously, as in clinical varicoceles, genital infections, smoking, obesity, age greater than 40 years. All of these become indications for where a sperm DNA fragmentation test may be considered. Next, please. So again, coming to the indications, repeated IUI or IVF failures, varicoceles, advanced male age, history of genital infection, smoking, other lifestyle risk factors, idiopathic or unexplained infertility, and recurrent spontaneous abortion. Next, please. There is some concern that if you are going to use sperm with high levels of DNA damage, will there be a problem with successful pregnancy? This is something that has not been very clearly defined, but it's a concern that exists in mind. Next, please. So we'll run through this very quickly. Next, please. Lifestyle factors: age, obesity, smoking, recurrent pregnancy loss. Next, please. There's evidence for all of this. Recurrent IUI failures. Next, please. Unexplained infertility. You found high semen DNA fragmentation in men with unexplained infertility. Next, please. IVF and ICSI failures. Now, this is where you have very variable data. In fact, if you look at recent meta-analysis, you will find that IVF and ICSI are not impacted by sperm, even with high DNA fragmentation. Though if you look at it in practice, and we can have comments by our IVF specialist here, but they would like or prefer men to have sperm DFI lower than 30% for better ICSI outcomes. Next, please. Again, sperm DNA fragmentation has been studied extensively with regards to varicocele, and we've seen some beautiful data which is put up. We can go to the next one. It has shown that varicocele increases SDF, and varicocelectomies can result in reduction of SDF. Next, please. This is the second problem with DNA fragmentation. Now, once you found out that there is high DFI, can you do too much to alter it? Unfortunately not. There's very little that you can actually offer to the patient in terms of what you can do to change DNA fragmentation. Lifestyle changes are the hallmark of what you can do, which means you ask them to lose weight, stop smoking, take away all the risk factors, take away the gonadotoxins, try to make them live in less high scrotal temperatures or cooler temperatures for the scrotum, use empirical medical therapy. If there is a clinical varicocelectomy is indicated. Short abstinence is something which has shown to reduce DFIs. There's a controversy regarding how much benefit testicular sperm instead of ejaculated sperm benefits for pregnancy outcomes. You may get better DFIs, but does it actually result in pregnancy outcomes? There is controversy for that. And then lab protocols, which are involved in terms of reducing the incubation time from when the sample is received to when ICSI has been performed to avoid iatrogenic SDF. Next, please. So again, here we've found out similar things. When you're using different studies and different cutoffs, what are the acceptable cutoffs? I think we've already discussed this, so we'll proceed with the next one. Next, please. And so with natural conception, what they found was that infertile men had who had significantly high SDF levels had lower conception rates. With IUIs, there was questionable data, and with ICSI and IVF, it did not affect outcomes. Next, please. What are the lifestyle changes that you will introduce? Avoid hyperthermia, minimize gonadotoxins, avoid occupational hazards, and regular exercise. Next, please. How much data is there for antioxidants to reduce SDF? This is limited, though there is some data for empirical medical therapy to affect the ROS, which may be responsible for increased DNA fragmentation. But in terms of empirical medical therapy for idiopathic and unexplained infertility, the results are not out yet. Next, please. Varicocele, yes, we've seen the data, and yes, clinical varicoceles, which, per se, is SDF just an associated factor, or is it the responsible factor? There is question about that. But yes, very much, because they go hand in hand. You will have a clinical varicocele, and if you do find high DFI, there is going to be reduction of DFI and improved outcomes. Next, please. Presence of genital infections will result in an increased semen DNA fragmentation, and treatment with appropriate culture sensitive antibiotics, frequent ejaculation, use of antioxidant therapy is known to help these men with higher DFIs. Next, please. Iatrogenic abstinence, iatrogenic damage, such as long abstinence or long incubation in the lab or improper handling of specimens, all of that can result in increased DFI. So if you reduce the process time, reduce the incubation time, avoid long incubation, and have short abstinence, serial ejaculation, this may all result in improved DFI. Next, please. Now, there is some data which has shown that SDF was 5-fold lower in testicular sperm compared with ejaculated sperm, and that live birth rates were better when testicular sperm was used. Next, please. But there's a controversy regarding this. And the problem is that when this was used, a lot of the things, especially with this data, was that a lot of the parameters actually changed between the primary conception couples and those that had had IVF failures. Because when you have an IVF failure and an ICSI failure, you don't only change the fact that the DFI is altered, you only change from ejaculated to testicular sperm. The protocols also changed, certain medication changed, certain other variables came into the picture, and it's not been clarified that it was only the use of testicular sperm which resulted in a better pregnancy outcome. Unfortunately, it starts not from there, not from there only. It starts from the fact that DFI assay by itself has been questioned, as I've shown before. There is limited data which shows which particular type of test that you've used is reliable. Again, there is limited data to show that it's only the elevated SDF which has resulted in the ICSI or IVF failure. So when we don't have conclusive data with regards to the role of DFI per se in it being a good assay or it being responsible for failures of IVF and ICSI, we can't then predict that the testicular sperm which had lower DFI has a better outcome compared to ejaculated sperm. So this is still not out there. Recent meta-analysis by Niederberger actually found no benefit of testicular sperm. So there's still going to be a lot of back and forth between what is better, whether the testicular sperm has that huge advantage over ejaculated sperm or not. Next, please. We've discussed the sperm selection techniques. I will not touch these because we've had a previous talk where sperm selection methods have been discussed. But abnormal sperms can, when all these methods fail, can go through these tests which have been previously discussed. And though we're still yet to reach there in terms of what is the best possible method, but you could possibly look at MAX, microfluidics, or PIXI, and see if you can have better selection of sperm with lower DFI and better outcomes. So you have an infertile couple who's come in for evaluation, and you have this history of either unexplained or idiopathic infertility, recurrent miscarriages, lifestyle risk factors, varicoceles, recurrent IVF failures, and you find high SDF in these. With varicoceles, you would recommend a varicocelectomy. Whereas for others, you would treat depending on what is the causative factor to lower the SDF, which means you would allow frequent ejaculation, antioxidants, lifestyle modifications, and control of underlying any infection or inflammation. If high SDF still persists or you have history of recurrent IUI or IVF failures, you would then go in for an ICSI procedure, which is shown to have a less impact of raised SDF. If you still have a higher recurrent miscarriage rate following ICSI and you still have high SDF, then you could go in for sperm selection, sperm source processing and preparation methods, or the use of testicular sperm. So this is the current expert recommendation that we have. And this kind of a protocol actually suits us a lot. This is what we follow in current practice. Next, please. So DFI by itself is a useful tool for unexplained idiopathic infertility or recurrent abortions, recurrent pregnancy failures, or IVF ICSI failures. There is no ideal test, though most commonly we use halosperm, and the SCSA, if available, is more accurate. Though you have to remember, this is a recurrent test. You're going to do a test at baseline when you've got a patient who has all these risk factors, and then you're going to repeat it after you've put in some therapy, and then you're going to repeat it if there's a failure. So you should be able to do a test that is more repetitive also. You treat and remove the causative factors, institute lifestyle changes, advise frequent ejaculation. In some cases, testicular sperm may be better, and ICSI failure, though it may be high with greatly elevated DFIs, you may improve it by the newer sperm selection methods. Thank you for your kind attention.
Thank you, Dr. Finit Malhotra. Very interesting and very useful for us. There are some questions. First is for you, Dr. Finit, that how does abstinence reduce sperm DNA fragmentation? Abstinence reduce DNA fragmentation.
So the belief is that the newer sperm will be less affected by DNA fragmentation. In fact, that's the sense and understanding between using testicular versus ejaculated sperm also, that the travel within the epidermis is going to allow more of the DNA fragmentation within the sperm. And similarly, when you are using shorter abstinence, you allow the newer sperm which has been collected to then show up in the ejaculated sample and show up with lower DFI. In fact, that's been studied. So there's been shown that there is 25% reduction with a serial or sequential ejaculate sample.
Okay, thank you. There's a question. This is for Dr. Oki especially. How about the Parkinson disease and infertility? Can we explain that?
Explain about Parkinson disease and become infertile, or how should we treat patient with Parkinson disease?
Yeah, the mechanism, pathophysiology, and how should we treat?
Parkinson disease, we actually during our consultation, there are not much patient Parkinson disease with infertility. Normally, patient with Parkinson disease in elderly age, normally they have already children, normally. But if we look at the possibility of Parkinson disease, normally Parkinson disease has no sexual dysfunction. Normally, the sexuality is normal. Patient with Parkinson disease, yeah. And hormonal changes, I don't think there is a direct relation between Parkinson disease and infertility, but we have cases with patient become like he married in older age and has Parkinson disease and have a problem, and we do ICSI on them, on the patient with Parkinson disease. But they still can masturbate normally in the morning when they are just wake up. They are very tidak kaku badannya, masih sehat, masih bisa lemes, dia masih bisa masturbasi. Yeah. We have patient, I think I have a patient from you which has also a stroke, and I asked the wife in the morning to collect the sperm, wake up in the morning and then masturbate. There are some few sperm, and then we freeze and then we do ICSI, and a female girl were delivered from that.
Thank you.
Yeah. I have one patient from you coming with many guardians at that time. You remember old time before. Yeah.
Okay, thank you. There is a question for Dr. Ayudhya. Are there any effects on tolerance and efficacy from consuming tadalafil for long-term management of ED? Should we be concerned of potentially changing the drug dose or dosing interval? Please, Dr. Ayudhya.
Yes, thank you. I think this is an interesting question to be discussed between the panel members. But I believe that most data on tadalafil at the moment, there is mostly consistent efficacy, even in up to longer term. However, of course, with any medication that is taken for a long period of time, there is some discontinuation, especially in daily practice. We see this is mostly cost related. However, consistent usage these days is mostly concerning low dosage with add-on for when necessary. I don't think there is any concern for tolerance. The other panel members maybe have more experience.
Dr. Finet, please.
Yeah, we've not seen or no data which has mentioned that there is a particular risk of long-term tadalafil therapy, and we found we've in fact had a lot of data where it's been used in low dose on very long-term samples. So that is not a problem, and neither is tachyphylaxis a issue with the long-term therapy of tadalafil.
Thank you. Dr. Oki, any experience?
We don't see any as well, the same.
Yeah. And Dr. Fikri, comment?
I think it's the same, Prof.
Yeah, okay. We can also still add on. There's a question for Dr. Fikri. Which of these parameters evaluated using ultrasound is more correlated with sperm quality, peak systolic velocity, or varicocele grade?
I think it's the varicocele grade using the diameter of the vein. In my opinion, probably Dr. Finet will have an opinion about this.
Now, this is very interesting to answer because I actually do not use an ultrasound to diagnose or base my treatment for the varicocele. A clinically diagnosed varicocele is a varicocele that is operable. And I, in fact, find very poor correlation between ultrasound. PSVs we never use, but varicocele grade only for a subclinical varicocele on the contralateral side. So for me, the ultrasound is not an important investigation for varicocele until unless I have problems in identifying the man is very obese, he's had previous recurrent surgeries, and I'm not able to examine him properly.
Okay, thank you. And next is Dr. Oki. Are there any studies evaluating possible hereditary or genetic disorders in fetuses conceptualized from patients with azoospermia, cryptospermia, and necrozoospermia?
So far, I don't see any data for that. But so far, patient azoospermia, mainly due to obstructive azoospermia, the result is almost similar with the result of other cases of ICSI. From patient with necrozoospermia, that we found in the ejaculate there is no more sperm in it, and we found from the testis almost the same. The pregnancy is also similar with regular ICSI, and with cryptozoospermia is the same. But I don't see there is any data hereditary to look at the children of this azoospermia, cryptozoospermia, and necrozoospermia.
So,
Dr. Philip.
See, the important thing to understand is that the difference is between whether you're using sperm from non-obstructive azoospermia patients or from obstructive azoospermia patients, and that's where we found this difference in possible hereditary or genetic defects in fetuses. And that's the similar thing that will be there with cryptozoospermic or necrozoospermic. You just have to consider them like non-obstructive azoospermics, and then the rates or ratios are similar to those, rather than the men that have obstructive and almost normal sperm quality that we are dealing with.
Thank you. Very interesting. And next is there any difference in sperm DNA fragmentation results between sperm chromatin structure, sperm chromatin dispersion, commit, and tunnel assay test?
So I think I mentioned this in my slides that there is a lot of difference if you look at results only in terms of what you're seeing on the lab report. The results that come in from an SCD or a sperm chromatin dispersion are far more variable between lab to lab, and the assay results are different from even center to center. So I may have 20% and below as normal and above that as abnormal, whereas a lab just 5 kilometers from here might label a 30% fragmentation limit as a cutoff. So the cutoffs are also variable, and the inter-observer results are also variable. There is much less variability between observers when you're using anything else, whether you're using SCSA, Comet, or Tunnel. So vis-a-vis accuracy of tests, the SCD probably is the poorest in terms of accuracy, but the most commonly performed test. And all the other tests are far more accurate, but there is a lot of difference in cutoffs between different centers for all tests concerned.
So it's mean that we still have time to wait until some results coming for
Actually,
using
both.
the SPF.
Actually, both. So if you have availability for your own observer, which means when you are using within the same lab. So what I tell my patients and what I explain to people is also that inter-observer is all right. But when my own observer has labeled it as 25% today, and after 3 months he says this is 35%, or he says it is 15%, he's the same observer. So for his standardization, this is standard. And we will understand that based on his reading, you have either improved or not improved, which means I recommend that don't change the lab. This is something, I think this is a message that has to go out with DFI very importantly. Do not change the lab when you're doing DFI assays, because you'll get different cutoffs, different values every time. Have the same observer follow up the patient, because then it becomes standardized. It's the same person who has seen it before, it's the same person who's seeing it now. If he's seeing a lower fragmentation, yes, there is improvement. So that's something I definitely recommend, whichever test you may be choosing.
Okay, thank you. Is there any other questions? Yeah, Dr. Ayurya, is there any correlation between either infertility or sexual dysfunction with masturbation among male? Is there any correlation? Are there any potential treatment for said problem?
Yes, thank you. I think the question is rather complex, and we would need to have more personalized counseling, because this is related to sexual behavior as well as personal concepts. In general, the masturbation in our communities may be a complex issue. Some will see it as sinful, and when it is done, this will also relate to concepts of unrealistic sexual expectations, and that will of course lead to sexual dysfunction. So I think sexual education and psychosexual counseling, if necessary, is if there is a problem, of course, that would be needed. But with infertility itself per se, I do not see a direct relationship.
Okay, thank you. And now we come to a case discussion. Please, the first case. Okay. Male, 32 years old, married for 4 years, never fathered any children. Sexual intercourse 3 to 4 times a week without contraception. History of smoking and comorbidity denied. No past illnesses and medication. Next. And the external genitalia, mass on the right and left. Spermatic cord seems like a bag of worm, visible and palpable at resting position. The lab result, the FSH 9, LH 10, testosterone 1,100, sperm analysis 2 cc, 4.7 million per cc, and motility 28%, morphology 2%. Next. And these are the ultrasound results. Yeah. Okay, exaggerated during standing and falsafa. Next. Yeah. Normal right hemiscrotum, multiple dilated serpiginous vessel superior to upper pole of the left testicle, 4 millimeter in supine position, and the appearance are exaggerated during standing and falsafa maneuver. No flow reversal. Then varicocelectomy. Sperm analysis after surgical procedure, after every 3 months. The first follow-up, the first 3 months, semen 2 cc, concentration 4.5 million, motility 27%, morphology 2%. And then still after 6 months, motility 30%, concentration 6 million. And after 3 months, 6.5 million. Yeah, and after 9 months, 2 cc, 8 million. Next. What will we do for this patient? It seems that the result of the varicocelectomy is not very satisfying. Dr. Finit.
So we have to understand that there is a maximal fertility potential of a male, irrespective of the surgical procedure and technique that we use. And if we have made certain that there is no recurrence of his varicocele, then we can now offer him, because if we look at 3 monthly follow-up for 4 follow-ups, which means he's done 1 year of follow-up following the varicocelectomy, I would recommend him to then move to assisted reproductive techniques.
Any other opinion? Your experience, Dr.
Prof, can I have an opinion, Prof?
Oh, okay. Yes, Dr. Fikri first.
So I think I agree with Dr. Finet. We should check about the varicocelectomy. Is that okay or not? Probably we could check the ultrasound again after the operation, whether there is still a recurrence of the varicocele or not. If there is no recurrence of the varicocele, then we should do the IVF. I think that's Prof.
So do you mean that if there is still varicocele prominent, then we have to redo the varicocelectomy, or with another method, maybe with a microsurgical?
Yes, depend on the first repair. If the repair is sometimes the patient consulted from other places, like rural places, then we don't know how the method. Then we should, I think we should do the operation again. But if we are sure that the first operation is good enough, then we proceed with the IVF.
Dr. Finet, do you have any experience to redo the varicocelectomy?
Oh, yes, several times. We do need to do it both when done elsewhere, or if we have sometimes left a vein unattended and need to go in again. So we must not feel, we avoid making the error of missing any veins. But if by chance you have had a recurrence in your own operated case also, you would go in again, and I would still go in and do a microsurgical varicocelectomy again. But then there is also an option of the patient then choosing an embolization procedure if he wishes to. Though this is a rare occurrence, it's not the rule if you've done your varicocelectomy well and have done a good microsurgical varicocelectomy.
Yeah, Dr. Oki, how is your experience?
When I look at the first result, this patient has some problem with endocrinology. His FSH is rather high. The limit is 12, but the limit is about 8. Her testosterone is rather low, 1,100. When you failed like this, whether you have to look again on the result of your endocrinology, your LH, FSH, testosterone. Even you can give some medication that increase your testosterone and improve that. You can give letrozole, you can give clomiphene citrate to improve the sperm. If you want to continue conventionally without moving to ART.
So if you replace or you treat the hormonal situation, how long do you try to?
At least 3 months to 6 months.
3 to 6 months.
Yeah, 3 to 6 months. You can give clomiphene citrate or letrozole to increase the testosterone and to improve the hormonal situation. When you look at the before this, the result of the first, you should, when you want to go routinely, you don't go to ART. If you go to ART, then move to ART. But if you want to do it conventionally, you give conventional treatment.
So it depends also the age of the couple. Okay, thank you. Second case, please. Male, 30 years old, married for 2 years, no child, history of hematospermia, urethritis, prostatitis, frontal enlargement. No smoker, no past illness or medication, came with sperm analysis from 3 and 5 months before oligoastenozoospermia. Next. Both testes with a normal limit, palpable enlarged epididymis, fast difference available. The lab FSH 12, LH 11, testosterone 1,200, sperm analysis 1 cc, concentration 10 million, motility 23, morphology 21. Next. This is the transrectal ultrasound. Show that the ejaculatory duct and the posterior urethra and cyst and the ejaculatory duct. What is your opinion and treatment? Dr. Finit.
I would actually question why a truss was done in this case. Now, he's not an azoospermic patient. He has a 10 million sperm count, if I'm not mistaken. Even though it's low volume, it's a rare patient that we would look at as a partial obstruction with a central ejaculated duct cyst. And I don't normally get a ultrasound or a transrectal ultrasound done in such men. I would treat him with medical therapy and reassess. I would do a hormone profile. His hormone profile was also, again, it would depend. I would consider this as a borderline hormone profile with the lab levels not given, but I think FSH of 12 is marginally high. The LH also marginally on the higher side. And I would look at improving his, giving him, optimizing him with medical therapy for at least 3 to 6 months, and seeing and taking it from there.
Dr. Ayurya, your opinion?
Yes, I think urological. Well, a urological point of view, this is not a clear-cut case of obstruction. I think the approach outlined by Dr. Vinit, I would think that's very reasonable to do, especially considering that the age of the patient is still. We have a few more years to consider further follow-up.
Dr. Fikri?
Yes, I agree, Prof. So I think we should check it with more hormone profile and check it within 3 or 6 months until 1 year and check the hormone profile again.
Dr. Rocky?
Same, check the hormone profile and doing conventional treatment.
Okay. The problem is if this patient continue with hematospermia, what will we do? There will be a problem that we already treat the patient as a prostatitis with vitamin, but continue with hematospermia and he's very worried. Dr. Finet, do you have any experience?
If I had seen any calculi or if I had seen evidence of seminal vesicleitis or I would start with the symptoms. But if I had seen any of that and hematospermia, as you mentioned, then I would look at investigations more intently. Only a cyst in the ejaculatory duct is something, and again, this is not looking like a large central cyst. So this is not something that I would be very keenly attending to. But yes, if I find a large central cyst, and if I feel there's an evidence of infection within it and or inflammation within it, then possibly treating it could be a possible argument. Though I would be very, very reluctant to do that.
Okay, thank you. I have a question for Dr. Oki. A patient with leucospermia. We already treat with antibiotics and still leucospermia, more than 1 million. And the patient asked for an IVF program. How is your opinion?
Yes, normally with leucospermia long term, we culture the sperm. If the culture is negative, that's only leucospermia in the sperm because the infection in the sperm, leukocyte is high, but even without germ cell in it, you still have some leucospermia. And if we do IVF, we do a lot of cases, some cases of that. We do density gradient and take the lower part, we separate the motile sperm from the leukocyte, and we use the motile sperm.
Okay. The last case, please. 35 years old male, intercourse 2 times a week, married 5 years, unable to conceive with his wife, patient never fathered any children. Wife 29, undergone infertility evaluation, normal potency, normal libido and ejaculation, history smoking and comorbidities denied, no. But he has a history of cystic fibrosis in his family. And the physical diagnosis, normally circumcised, urethra also normal, testis normal, laboratory FSH 12, LH 9, testosterone 1200, prolactin 17, semen analysis 2 cc, no sperm. Next. Radiology, ultrasound, left renal agenesis, right renal within renal normal limit, and ultrasound of the scrotum. Both testes, no varicocele, normal. Next. Yeah, these are the transrectal ultrasonography, bilateral, seminal vesicle, and vas deferens. Yeah, next. What is the diagnosis and what would you do for this patient? Dr. Finet.
So I think we are apparent with congenital bilateral absent vas deferens in this patient. And for this patient, we would get a genetic testing for both husband and wife to make sure that the wife is not a carrier of the CFTR gene, because then you're looking at a life-threatening event in the cystic fibrosis in the pregnancy outcome. So once we have ruled out a carrier status of CFTR in the wife, we will then proceed with planning the ICSI for the couple and sperm retrieval. Again, I leave the choice of sperm retrieval to the fertility center, which means I can either do a epididymal aspiration percutaneously, microsurgically, or do a testicular aspiration based on what is the preference for the fertility center.
Dr. Oki, any experience with?
Yeah, the same. We are thinking about that, but I don't know. The population with cystic fibrosis here is not high in the Asian situation. Yeah, we are not doing the CFTR gene here. Normally, if we look on that case, especially the FSH is rather high, normally we do proof PESA. We do PESA first. When we found the sperm, we frozen the sperm. But when we don't found the sperm, then we tell the patient that there is no sperm in it.
Yeah. Any other opinion? It's very
can I ask something, Prof?
Yes, please.
Dr. Finet, do you have any experience between testicular mapping biopsy by Dr. Turet? I think it's almost the same with the needle aspiration biopsy, NIB, in India. What do you think?
I'm glad you asked this question, because I think Dr. Rupan and myself have very different ideas about testicular mapping. We only use testicular mapping as an intra-operative procedure at the time of sperm retrieval and never as a pre-diagnostic procedure. As it is, as we believe, there are very few indications for doing diagnostic biopsies in men with non-obstructive vasospasmia, until unless you have a confusion whether this is an equivocal case to differentiate between obstructive and non-obstructive. So what we prefer these days is to do a procedure that we call a single staged surgical sperm retrieval procedure, where we, if the volume of the testes is fine, begin with a needle aspiration biopsy, which is only a 4-quadrant biopsy. And if we do not find sperms in that, we proceed with what is called a mapping TSE or a SST procedure, where we do the Turek kind of 30 biopsy, microbiopsies after having delivered the testes and then doing it under microscope. And if we still don't find sperms, we then proceed with a microdissection TSE all in the same session. So since it is in the same session, you do not have the chance of then losing the sperms. Understand the difficulties with, and in fact, if you go through Turek's paper, some of the challenges that he's put up in that paper. So one, it's very difficult to actually map a testes like that. You may have held it like that the first time and put up all your numbers on it on the surface, but the testes very easily is mobile. And for you to get those same segments the second time around will not always be accurate. Secondly, it's been shown, and in his own paper, he's shown that he had an 88% recovery from men that had positive sperm retrieval at the first attempt. He doesn't freeze those sperms. He doesn't use those sperms for ICSI. He uses them only for diagnosis. So within the same men that actually had sperms in the first finding when it was a diagnostic biopsy, in 12% of those men, he did not find sperms again at the second setting. He found it in 88% of men. So that's actually a loss, because if you would have done it as a planned procedure with ICSI, you would actually have been able to use all those sperms. So what we actually recommend is that this not be done separate from the micro TSE procedure, but rather as a mapping TSE SST procedure at the time of the same session where you're going to attempt and ICSI. So you time it with the egg retrieval and you do it as a single session, but staged. You do the simplest stage which allows you to retrieve sperms. And that's what we do.
Yes, thank you. Thank you. Thank you all for the speakers and especially for our distinguished guests, Dr. Vinet Malhotra and Dr. Oki Inting. It was a very interesting and very good presentation and a very fruitful discussion. Thank you. Thank you very much. Back to the organizing committee.
Thank you for. We come to the end of the third webinar series. We are kindly reminding for all members of Ikatan Ahli Urologi Indonesia of East Java, there will be a meeting on the next Friday on 27th of November 2020 after the end of our fourth webinar. We apologize for all our shortcomings during this webinar. We hope that we can meet again on the next week on our fourth webinar. So please follow our Instagram at Fiesta Urobaya and contact our contact persons for the link of registration and any updates of Fiesta Urology. Thank you very much for your kind attention and participation during this webinar. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Dr. Vinet. Thank you. Thank you so much.
Thank you so much. Thank you, sir.
Ya, tadi Mbak Angel apa?